hospital care and experience, complications, roles of care, to palliation, hospice, and funeral readiness if needed. We shall have a separate roundtable dealing with the psychosocial aspects of COVID-19 from the community perspective as a dedicated roundtable at a later date. So please stay tuned. Before I introduce my panel today, I would like to give a shout out to all those frontline workers during this pandemic time for what you do out there. Thank you very much and be safe. I today have the utmost pleasure of introducing you to our panel members for this afternoon. I'll start off with Dr. Masood Ahmed. Dr. Masood Ahmed is a pulmonologist, a critical care and sleep specialist with UPMC Lidditz. We have Dr. Vinita Amanullah. She's a pediatrician with the WellSpan Medical Group. Dr. Shahid Babar, he's a hospitalist and also part of the administration at Lancaster General Health. We have Dr. Bashir Agiva. Dr. Bashir Agiva is an infectious disease specialist with the WellSpan Medical Group. We have Dr. Arif Hafiz, who is a hospitalist who primarily cares for patients within the LGH system. We have Dr. Tipu Salim, who is an endocrinologist with the Pennsylvania Institute of Endocrinology. We have Dr. Fariha Sarij. Dr. Fariha Sarij is an internal medicine physician with Lancaster General Health. He's also board certified in hospice and palliative care medicine. We have Dr. Samira Syed, who is an obstetrician and gynecologist with UPMC Lidditz. We have Brother Mukram Syed. He is a chemical engineer and is also a member of the Board of Trustees of the Islamic Community Center of Lancaster. And myself, Shakil Amanullah, I'm a pulmonary critical care and sleep specialist with the Pulmonary Associates of Lancaster. As a disclaimer, I would like to point out that this conference is only for informational purposes and should not be misconstrued as medical advice. You should still follow the advice of your physician. I would like to thank the Islamic Community Center of Lancaster for their support for making this program free to the audience. We shall start the program with Surah Al-Fatiha from the Holy Quran by Brother Ahmed. Brother Ahmed.
Assalamu alaikum everyone. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين. In the name of Allah, the most gracious, the most merciful, praise be to Allah, the cherisher and sustainer of the worlds, most gracious, most merciful, master of the day of judgment. To you do we worship and from you do we seek help. Show us the straight path, the path of those upon whom you have bestowed your grace, not the path of those upon whom you have given your wrath and those who go astray.
Amen. For the audience out there, you can see this program live. You can see this program live on Zoom. You can also see this program live on our Facebook. If you are having any issues with the audio, please send us a message. You can message us through the Zoom platform. I would like to start the session with Dr. Agiva. Dr. Agiva, if you can tell us something about this coronavirus. You know, the coronavirus has been around for many years, but why is this virus novel? Why is this virus different? If you could shed some light on that. If you could unmute your microphone.
Right, I muted myself. Assalamu alaikum. The coronavirus is a large group of viruses, and they were initially discovered in 1960s. And at that time, they were found to cause illnesses in both humans and animals as they do now. So some of the animals that have been affected by this virus include cattle, camels, cats, and bats. And rarely the animal coronaviruses can evolve into humans. And that's when they're known as novel, which is another word for new. And mostly the human coronaviruses that we know of are the ones they cause a significant percentage of colds. And so the majority of them actually cause like cold flu-like symptoms. And we do see a number of them during the flu season. And so far we know 7 strains of human coronaviruses. They're divided into 2 major groups, the alpha coronaviruses and the beta coronaviruses. We have 2 in the alpha coronaviruses. Those 2 are both causing only colds. And the 5 that are under the beta coronaviruses, 2 of them cause common colds, and 3 of them have been associated with outbreaks. So of those 3, the 2019 nCoV, which stands for nCoV, stands for novel coronavirus, is the third of those. The first one that was first identified was the severe acute respiratory syndrome, COVID, SARS-CoV, in 2003 in Asia. And the second one is the MERS-CoV, which stands for Middle Eastern Respiratory Virus. And that was initially reported in Saudi Arabia in 2012. And now the third one is ongoing.
Thank you. And as you, Dr. Giva, the WHO has now called the COVID-19 infection a pandemic. Mm-hmm. What is the difference between a pandemic and an epidemic?
So I'll start by defining an epidemic. An epidemic is defined as an outbreak of a disease that spreads quickly and within people and individuals at the same time. A pandemic is actually a type of epidemic. So it's in a larger scale, in a greater range, greater coverage, and kind of greater geographic area involvement. And there's no definite line between the two. A pandemic is definitely a type of epidemic, but an epidemic doesn't always get to the proportions of a pandemic.
Got you. Thank you. And when it comes to the COVID-19 infection, can you share with us, for the audience, some of the symptoms that could suggest that someone is having a COVID-19 infection? Also, when they should be, calling their primary care provider, and when they call their primary care provider, what establishes that that person, he or she, has a COVID-19 infection?
All right, so the common symptoms that have been reported so far include cough, shortness of breath, fever, chills, muscle aches, headache, and sore throat. Most facilities would use the main screening questions would be cough, shortness of breath, and fever. And also recently, new loss of taste or new loss of smell has been highlighted as one of the symptoms. So of those 3, of all of the symptoms I have just listed, if you have 2 or 3 of those, then we have to think of nCoV in the current setting. Other symptoms that have been reported include fatigue, mainly just feeling generally unwell and not really understanding any specific symptoms, as well as sometimes, usually the cough is dry, but sometimes people report sputum production, so they're coughing up phlegm, as well as diarrhea. Diarrhea has been reported, and of course, when the breathing difficulty gets even severer, it causes respiratory distress. So when you have symptoms like fever, cough, or shortness of breath, and you call your PCP office, again, those are 3 symptoms that they usually look out for. So once you have like 2 of those, they'll probably be asking you to go in for a test. Over the phone, it's difficult to say whether it's nCoV because again, most viral symptoms can cause fever, cough, and shortness of breath. But we know that when it's severe, we're seeing more shortness of breath with nCoV. But most of those viruses do cause a respiratory illness, so you would have respiratory symptoms. So, but over the phone, they use screening questions, and then they would send you to a testing center to get tested for the virus. And the lab test will then help determine whether you're infected with the virus or not.
Thank you. For the audience out there, as Dr. Giva has said, there are certain testing centers. It is good to give your hospital system, whichever hospital system you are with, to call them and find where are those testing centers. And also keep in mind that these testing centers they can move from one place to the other place, so you want to know where these testing centers are. My next set of questions will be going to Dr. Ahmed. Dr. Ahmed is a pulmonologist, critical care and sleep physician with UTMC Lidditz. Dr. Ahmed, just like Dr. Giwa has said, a common symptom with the COVID-19 are at that time of an infectious cause, but the spring allergies or asthmatic cough or the COPD cough is unfortunately a symptom that crosses over COVID-19 infection and other allergies. So what should be those symptoms? What makes those certain symptoms more concerning that I have to start thinking about a COVID-19 infection? If you could share some insight into that.
So the sister just mentioned the symptoms of COVID virus. So allergies most of the time can give you like cough, sneezing, itching, but high fever and shortness of breath is not very common just from the allergies. And the shortness of breath is also not very common. And additionally, most of the patients who have allergies, they have history of allergies and they know that it's allergy season is coming and they can recognize the similar kind of symptoms as they had before. But high fevers, shortness of breath, cough, and sometimes the GI symptoms, loss of appetite, diarrhea, these are the symptoms that actually point towards more COVID rather than the allergies.
Thank you very much. And unfortunately, there are still a lot of smokers out there, and we have the public who also vape. So patients who smoke and patients who vape, are they at risk for contracting the infection? And if they do contract the infection, are they at a higher risk for complications or both? If you could shed some light into that.
The smokers are definitely at high risk for getting this infection and having more complications from the infection, because from the smoking, their internal lung epithelium has damaged and they are more prone to get infections. And once they get infection, they are more prone to get complications. Vaping is also a risk factor. I can comfortably say that both for getting the infection as well as getting more severe complication from the infection. Nicotine patches, there is a lack of knowledge. There are not many studies having the nicotine gums and nicotine patches, whether they increase the risk or not. But vaping is definitely increase the risk for getting infection and getting severe infections. And smoking is definitely a risk factor for getting infection and getting severe infections. And they are prone to get more complication from the infection.
Thank you. Not only are we in the middle of a pandemic, we are also in the middle of an infodemic. I mean, nowadays we have the internet to our access. We have all kinds of information out there. And one of the things that a lot of audience members may be Googling and seeing is that, steroid is not a good thing for the COVID infection. But we know there are a lot of audience member and public out there who are already on inhaled corticosteroids, the inhaler that contains steroid for asthma, COPD, rheumatoid arthritis, or lupus, or even controlled asthma. What should they be doing? Should they be stopping steroids, or should they continue and to optimize whatever the morbidity or disease condition they have and not change that? How do you get this, Dr. Ahmed?
Very good question. So the general recommendation is if somebody is taking inhaled steroids or even the PO steroids for their asthma or COPD, they should just continue using it. because not controlling their underlying disease, asthma or COPD, can put them at high risk of getting infections and getting severe infections. So the general recommendation is if somebody is already on inhaled steroids or the pills, steroids, they should just continue using their management for asthma and COPD. They should not be stopping those medicines.
Dr. Shakir, I think
Yeah.
I think your connection.
Can you hear me? Can you hear me?
Yes.
Is it my connection?
Yes, probably, but we can hear you now.
Okay, good. All right. Thank you, Dr. Ahmed. The other thing I would like to, I'd like to move on to Dr. Giva. Dr. Giva, a few questions regarding how does this coronavirus spread? What can we do to prevent or reduce our chances of getting this infection? If you could share some light on that.
All right. So the coronavirus is thought to spread by droplet, and a droplet is really particles that are released from our airway, our noses and mouths. So mainly they're spread by when we cough, sneeze, and sometimes if we exhale and inhale, just breathing can release those particles. And when they're termed as droplet, it's the particles that will drop within 6 feet of us. And that's where the 6 feet social distancing comes in. So it will fall within 6 feet of us. So if someone is within 6 feet of us, then it could fall on their face, their nose, their mouth, their eyes, and it could get into the system that way. And if not, then it will fall on the surfaces near us within 6 feet. And that's where contact with surfaces come into play and why we need to be disinfecting those surfaces. So that's the main route that is known. Another route you would have heard of is airborne, and in terms of using a special mask called an.
Are you able to hear me? I had to.
Sorry?
Sorry, go ahead.
Okay. So another is airborne, and this is uncertain as to if this definitely spread by airborne, but in the hospitals, what CDC is recommending and what hospitals are adopting is that people who are likely to aerosolize those particles. And what that means is to kind of make those droplet particles become like airborne. So people who are intubated, so they have a tube down their throat and then those people who are getting breathing treatments, and you probably have heard that patients who are hospitalized, we try to avoid doing those treatments if we have to. So rather than using like a nebulizer, you use an inhaler, that sort of thing. And then how do we prevent the spread? Again, that's where physical distancing or social distancing comes into play, so that we are not spreading it without knowing. And also wearing masks. So the mask is really for me to protect the person next to me. So that way, when everybody's wearing a mask, then we're all kind of protecting each other. So keeping our droplets to ourselves and not spreading those droplets. And how physical distancing works is that you're, as much as possible, trying to stay 6 feet apart. And if you don't have to, you're not going out and about. And then you're even you don't want to, you want to follow the limitations set by the government as to not going beyond like 10 people in a gathering. And even then you want to be observing physical distancing in that situation.
Thank you, Dr. Giva. My next set of questions will actually be going to Dr. Babar. Dr. Babar, you know, is this whole COVID-19 all a hype? Or is this something that I should be really concerned about? There are these questions in our patients and our audience mind as to whether it is blown out of proportion. What should be the concern about this COVID-19? If you could share some light on
that. Thanks for the question, Shakil bhai. Yes, it is a real concern. As you can see, whole world is locked down, not for no reason. There's a lot of misinformation around in media, Facebook, which many people are spreading. Facebook actually had to hire individuals to take down this false information. But you can see, all the major universities in Europe, in UK, and starting from China, they're all doing hundreds of research on this virus, especially in making for vaccine. And as Sister Bashira describes, this virus is real. We should be concerned about getting it. The virus behaves in a strange ways, different symptoms in different patients. People can be asymptomatic and still acquire the virus and pass on to others. So as Sister Bashir described, the social distancing, keeping masks on, 6 feet distance from others, reducing the time of the exposure. These are very, very important at this time.
Thank you. And I know, Dr. Babar, you are associated with different prediction models. And can you share a little bit on what is the current state of our prediction models in terms of how does it, looking forward, how does it look like in terms of Lancaster County? Can you shed some light on that?
Yeah, so most hospital and health systems use something called CHIME model or CHIME model, sometimes they call it. There are other models too. These models are changing week to week and highly sensitive based on how many admissions are in the hospital of COVID patients. So as the admissions reduce, the model prediction gets better, and if the admissions worsen, the model prediction gets worse. The other factor which influences the models are, again, social distancing in the city, how people are behaving around. Are they entertaining the precautions or not? The Lancaster city, again, we were lucky that we got some lessons from other cities, especially New York and Philadelphia, and being part of Penn Medicine at LGH. Luckily, we did not have too many admissions as the other northeastern part of America, so especially the big cities. So at this time, I can share that the model says status quo. We don't see increase. However, as I said, this Lancaster city is opening up. The state is opening up. We have to see how this affects the hospital admissions, and the model will be revised again on a weekly basis. So we'll see how it shows in a couple of weeks. But at this time, thankfully, the model shows that there's stability in virus acquisition and numbers, and that's where we are at this time.
Right. So, many states have opened up, and Lancaster at some point will open up. When the city opens up, can I feel confident or positive that I can let my guard down? Should I go to go back to normalcy? Is that something I should be doing, or I should be cautious about even if we open up?
So yeah, this is a tough question. That when a city should open, as you know, between governor and local officials, there was some disagreement. Most of the southeastern Pennsylvania near Philadelphia is in red color, we call it, still in the danger zone, that the governor prefers not to open. However, the local Lancaster officials, they have moved the city to yellow. It means some small businesses can open with precautions. So precautions means, again, using appropriate protections, PPE, keeping the safe distance. There are many criteria when a city should open. For example, one of the criteria is if there are less than 20 or so cases per day for 2 weeks, or less than 10% of those who are tested are becoming positive, then we may open the city. Lancaster is still on the higher side. We are seeing somewhere around 40 to 50 cases per day in Lancaster County. Today's numbers were around 2,470 cases with the 247 deaths, mainly in nursing homes, which are already isolated. However, as the Lancaster city opens up, small businesses, I just heard the Central Market is open. So again, when we go to these places, we need to entertain all precautions. Mind you, all these businesses are also interested to provide confidence in customers, that they want to make sure that when customers enter, they see that this facility has any kind of business has appropriate precautions. So then customers will be more eager to utilize their services too. But in any case, we ourselves should be careful because this disease is still spreading fast in many areas.
Thank you. Also, Dr. Barber, many procedures, many testing at the hospital, at LGH, have been put on hold because of the COVID-19. So many patients are wondering, actually, when are they going to open up? When can I start getting my tests that are due, CAT scans and things like that? Can you give us some insight into over that?
Sure. So yeah, we had to, and as many hospitals had to hold on to the elective procedures, especially emergency procedures were still continuing. However, this week, endoscopies or day surgeries, I would say, where people don't have to be in the hospital overnight, they opened up. And then from next week, many of the what we call medically necessary surgeries, which patients cannot delay, they will open up as well, and some elective surgeries as well to some extent. Hospitals are all over the country where these things are opening. They're using all the precautions, protections for the patients and for the staff themselves. And then one of the things which you will hear if you are having a surgery, that you'll be asked to get a COVID test just before the surgery. That's necessary for most surgeries who are, for the patients who are staying overnight or more than 1 day in the hospital. So for almost all invasive procedures, the COVID test will be asked to get done a day or two before surgery. So, but again, as I shared earlier, the hospital wants to commit to patient safety and staff safety. So when you go for such procedures, just follow the instructions the hospital provides you.
Thank you. And one of the things a lot of audience might have read about on the internet is herd immunity. If you can shed a light on what is herd immunity and is it protective? Do we know it's protective? Where does science stand at this time with reference to COVID-19?
So herd immunity, if you want to define it, it's just a higher proportion of individuals in an area who are immune to a disease. So if we have quite a bit exposed population in Lancaster, for example, to coronavirus over time, then we can presume that they will develop some kind of immunity. The other way of getting immunity to this disease is through vaccination. So as you know, we are maybe 6 months to 1 year plus away for the development of vaccine. It's still in phase 2 trials, and there are some good results in animals testing that we may have vaccine in few months to 1 year. However, these immunity or the herd immunity, as I described, does not mean that you cannot get infection again. So I can share a simple example like flu. So as you know, most of the healthcare professionals and many population members, they get the flu vaccine every year, but they still get the flu. However, the benefit is that when they get the flu, to fight the flu, it's easier if you have a vaccine. So this is all presumptions that if you have a coronavirus infection already or in future when the vaccine is available, that you may be able to fight the next coronavirus better even the best vaccine will not be able to prevent, or the previous infection will not be able to prevent the next corona infection, because this virus, just like flu, mutates very fast, and then we may see more mutations down the road. So this is something about herd immunity that I shared.
Thank you very much. I'll be moving on to now Brother Mukarram, who is a Board of Trustee at the Islamic Community Center of Lancaster. Brother Mukarram, can you tell me what has the Islamic Community Center of Lancaster taken? What steps have they taken to prevent the spread of the disease amongst its congregational members?
Since early March, I think it was the second week of March 10th, we were very proactive, and unfortunately, we had to suspend all congregational activities. Like Jummah prayer, daily 5 prayers, Sunday school classes, halaqas, and pretty much all activities which physically brought people into the center. And very soon we adapted technology. So a lot of these activities were transitioned to an online presence. Like Sunday school started to conduct online classes on Zoom and Google Hangout, and I believe the Sunday school just had their last session, last class last Sunday, May 10th, and they're going to have a online graduation tomorrow, Sunday the 17th of May. So we have tons of activities online, online halaqas, football gatherings, many special events. So I think I urge, if you have not already done, to subscribe to ICCL's YouTube channel. Then you can also be a part of these virtual gatherings. So another thing which happened was April 24th was the beginning of our holy month Ramadan. So Ramadan is, when we have a lot of get-togethers to break fast, many community iftars and so on, and a lot of spirituality, Tarawih prayers and stuff. So, but one thing which really brought the entire community, was the iftar. So what we have done is we have taken this opportunity. We know because of the COVID, many families are, are experiencing hardship, and a lot of our, healthcare workers or first responders are busy. So we have been providing free iftar almost every day. Almost every day, we bring people, we take a meal to a police station or a hospital or different places, and appreciate their services by providing meals and other, we also do some other projects as well. So, and then the meal has been very successful. People come and, they're in trouble, in need. They're all calling, and they're very appreciative of the service. Similarly, we have been creative with our food pantry or groceries and things. So what we have been doing is we are doing a drive-through food groceries giveaway. And it depends on, sometimes we are very cognizant about the social distancing. So we announce the event, and we take the orders, and we take the we ask people to call and get on our list, and then we call them and say, hey, come on this timing, and then we deliver their groceries or food, anything during those times in the parking lot. This weekend, we are actually going to start a community iftar, which is a drive-through community iftar today and tomorrow. And between 6 and 7, we will have the schedule. We'll have people drive in, and then we'll place the iftar in the trunk or of the car without any interaction, maintaining the social distance. So you're welcome, the listeners, all are welcome to join the community iftar, as well as if anyone is in need for the groceries or food items, let us know, call message directly to ICCL.
Thank you. So just like you have mentioned, so all these congregational activities that physically bring in the public congregants into the center has been suspended. Yes. When do you foresee them opening up? When is this going to open up? Do you have any thoughts?
Yeah, that's a very interesting question. I mean, a lot of people have been asking that, and but the reality is we are we continue to be in the midst of this pandemic, right? This is the pandemic of a lifetime. Lancaster County is under is actually in the red phase. I heard Dr. Shah had talk about that the city is deciding to go on yellow, but still the state recognizes this as a red phase. And even if it moves to yellow phase, in red phase there are 10 congregants are allowed. In yellow phase it's 25. Okay, regardless, I mean what we want to do, what the center does really matter in the spread of the disease control within our community as well as the community at large. So there still is no effective treatment for COVID. There is no vaccination. There is no effective medicine. So the board and executive council is meeting regularly. We assess what's going on politically, from the state, and what's going on from medically, and when it is safe to resume some or all our activities, we'll open the doors. We are a faith group, we are welcoming. We want to open the doors for the worship of the Lord. So it's a house of worship. It's so we are looking forward to it, but regardless, the safety of community members comes first.
Well, I'm very glad that the Islamic Center is really being very proactive and very cautious about that. We are in the last 10 days of this month of Ramadan, and it usually culminates with the Eid prayer. Traditionally, our Eid prayers has always been together when the groups of people come together. Are we going to have a congregational Eid prayer this year? So, Eid Salah or Eid prayer as a congregation has to be, suspended. Okay? Eid is on May 24th, which is Sunday, next week. So we will have an online Eid khutbah gathering, okay, around 9 a.m. And the faithful can pray Eid prayer with family or individually, according to their case, and then listen to the online Eid khutbah. The Fiqh Council of North America has issued a fatwa meaning ruling regarding conducting the Eid prayers in light of COVID-19 lockdown. And this is the position, we follow the Fiqh Council's position, and it's very timely, so this is what we're going to be following. Sounds good. So what you're suggesting is listen to the Eid sermon, Eid khutbah, and pray with your families, but pray at home. Right. So the Eid Salah is done such first we pray, and then we listen to the khutbah, and then we greet the family and friends, Thank you. Thank you very much. Next, I'll be moving on to some endocrine questions. So I will ask Dr. Salim, our endocrinologist with the Pennsylvania Institute of Endocrinology. Dr. Salim, one of the things that we are seeing in COVID patients are if they have more comorbidities. That means to say if they contract the disease and they have diabetes, high blood pressure, hypertension, connective tissue disease, underlying lung disease, renal disease, they're at a higher risk for complications as well as a higher risk of mortality. Now, in our community, diabetes is not infrequent. So there are many people in the audience who are listening to us right now who's wondering, what should I be doing? Can you elaborate and also advise the diabetics in our audience regarding what they should be doing during this pandemic?
Thank you, Shakil Bhai, for giving me the opportunity to speak up on this forum. As previous speakers have eloquently described the health hazards of COVID, we know that on an average, the risk of having a severe disease is around 30%, and the risk of dying from this disease is up to 1 to 3% on an average. However, if we dissect it out into different groups, there are certain factors which would make a person more prone to get a severe disease or to recover early. So of course, age is the biggest factor. So, anybody who is younger than 10 years old, the risk of dying is almost 0%. Whereas if somebody is above the age of 80, that risk is up to 15%. And then we know male gender is a pretty high risk compared to the female gender. We don't know why which virus attracts men more. Of course, we can't change these two factors, but we could probably advise our elderly population to follow more precautions. But there are certain other risk factors which may be modifiable. Having a heart disease puts a person risk of dying almost up to 13%. And then comes the diabetes, which raises this risk up to 9%. And then comes asthma, cancer, weight gain, which is up to 7 to 8%. So why diabetes? Why diabetes increases the risk of severity of COVID infection? Diabetes have a double hit. Our body have an immune system, some sort of soldier cells which fight viruses. And at this point, that's all we have for COVID. All we have is our immunity, our immune system. And diabetes and high sugar, it does affect the immune system adversely. In general, diabetes does affect the immune system, and any infection could be more severe in diabetes. And same is true for the COVID infection. So generally speaking, if we would control our diabetes well, our immune system would be better, would be in a better shape to handle and fight against this disease. Now, the second hit we get from diabetes is the high sugar cholesterol that acts like a sludge, and it blocks our blood vessels and makes clots. This COVID infection have receptors and attacks lungs, liver, kidney, and then the blood vessels. And then our immune system tries to fight it. And as Sister Bashira mentioned, it's a new virus. Our immune system have no idea how to fight it. It starts throwing all its chemicals, antibodies, and things against it. And there's some lot of collateral damage in our body. So the blood vessels get blocked and they get clots. So along with pneumonia, it's the clotting, the strokes, the heart attacks, which are seen more and more in COVID infection. And diabetes makes a person much more prone to that. So that's how it's kind of very important to keep the sugars under control. So all the patients who have diabetes, of course, they have to follow the isolation precautions much more. They have to check their sugars more rigorously. And they have to follow their doctor's instructions. They may, if they're on 2 pills, may need to add a 3rd pill, may need to use insulin. And as a general precaution, anything which would prevent clotting would help, having less complications from this disease. We do recommend now our younger population maybe start a baby aspirin that could help prevent those clots. So that's why it's kind of important to keep the sugars under control during this situation. And the diabetics have to be much more cautious with their self-isolation.
Thank you, Dr. Salim. Also, we are in the midst of Ramadan, and any tips as to how we should be diabetics out there, even if they don't have the COVID infection, because we're in the midst of the Ramadan season? Any tips as precautions what they should be doing with their insulin regimen or the diet?
Yeah, so generally speaking, Ramadan and fasting, of course, it has a lot of spiritual aspects, and the prime spiritual aspect is a self-control and discipline. It does teach us self-control and discipline, which would be good against any disease. But generally look into it, how does fasting could help, irrespective of diabetes too. So, our body have 2 ways of handle the energy sources. When we eat some food, it has either carbohydrates, proteins, or fats. So carbohydrates are broken down into sugar, and we use that sugar as a fuel for our energy. Now, we have seen that, if there is too much sugar in the body, that would be bad. And there are a lot of new techniques coming irrespective of religious fasting, what we call intermittent fasting. And, we heard about keto diets. So when we fast from dawn to sunset in Islamic faith and other religions also, there are concepts of fastings, our energy source moves from glucose to fats. So fats start melting, and we go more towards a different kind of fuel for our body, which we call ketosis or ketone bodies. So that's really healthy for the body. There's a lot of research going on that these ketones are better for the heart. They are also better for our immune system. So fasting has a lot of good benefits, provided we follow the main theme of self-discipline, that we don't overeat in our our pre-fast dawn meal and in our post-fast sunset meal. And that's true for diabetics too. So the diabetics can discuss with their doctors whether they can fast or not. Of course, if somebody is very brittle, type 1 diabetes on a lot of insulin, it may be advisable not to fast. And, of course, religion have relaxations for that. Scholars can explain more. But if they do want to fast and if their diabetes is under control, then there are different kind of longer acting insulin regimes which they can use. Don't use the short acting insulin regimes. There are some diabetic pills which bring the sugar only back to normal. They don't take it below normal. There are some pills which can take it even below normal. So they can avoid those pills. And then I think most important thing is, again, not to overeat for the dawn meal, and especially after breaking the fast.
Got you. And now, many of the, when it comes to exercise, because of the social distancing now, any suggestions on how we can get our exercising when we cannot go to the exercise centers? And any thoughts on that, Dr. Salim?
Sure, I love that question. So the diet and exercise are the prime factors for having a healthy body, and healthy body would have a healthy mind. And these healthy techniques would probably make us having a healthy soul too. So basically we should eat 3 meals. Generally speaking, irrespective of COVID, we should eat 3 meals, spaced around. We should eat slowly so that we get satiety early. It's always advisable to drink water with the food, sip by sip. That again fills our tummy and we don't overeat. And definitely we should add some antioxidants in our diet, some fruits and vegetables, which actually does enhance our immunity, which may be particularly important in this COVID season. And then the exercise also helps prevent diabetes, heart attacks, strokes. And, we, as the doctors, advise minimum of 30 minutes of exercise 5 days a week, on top of whatever our other daily activities are. Now let's talk about COVID and social distancing and how we can practice diet and exercise in these hard times. So COVID and social distancing is pretty hard on, on economic situations or on work situations. However, it does give us a window of opportunity to what I call is social interaction. So I think the social distancing might be a misnomer. We can actually improve by doing the social distancing from others to do more social interaction within a family. So many families have came together because of this social distancing. We have less work hours and we have more time for ourselves. We have more time for exercise. So, like what we do in our family, we go outside. So exercise outside would be much better in the COVID season. Of course, we can keep the 6 feet distance from other people, but the virus transmission is not as speedy outside compared to indoor. So going for a walk with the family, maybe buy some bikes and go for biking, hiking, explore the wilderness nature around us. It's a good time because we have some time. So I think one thing which we may not understand is that being overweight does decreases our immune system, and exercise does enhance our immune system. The other thing which I want to mention relates to COVID is the diet. When we talk about a balanced diet, some proteins, carbohydrates, not to overeat, another important factor is that fruits have antioxidants. Antioxidants are the things which improve our immunity. Because of our lifestyle, we have done a lot of social distance from those antioxidants. Some of them are known and some of them are unknown. Especially, there's a lot of social distance between the plant and the shelf of giants and our fridge and then our tummy. So what we could do during that, we could decrease that social distance. We can improve our social interaction with the nature. We have bought some mint, cilantro, you can put it in your backyard or even in some pots in your kitchen and add to that diet. So a green leafy leaf from the giants may have much less antioxidants compared to if you just pluck it and eat it. So I think, this social distance and COVID, yes, it created some hardships, but it has created a window of opportunity to improve these within family social interactions in our social interactions with healthy living and with our environment and nature.
Thank you very much. That was very interesting insight. And I'm going to move on to Dr. Hafiz. Dr. Hafiz has been dealing with a lot of inpatients with the COVID infection at Lancaster General Health. Dr. Hafiz, the next set of questions will be for you. Dr. Giva had mentioned, once you have gone to your primary care doctor and your diagnosis of COVID has been established, probably not all patients have to make it to the hospital. But unfortunately, sometimes we do have to come to the hospital. So if you have a patient who is at home and has been doing well, but now is not feeling that great, when should he start thinking about it's time to go to the emergency room or urgent care? I was wondering if you could help us navigate that process.
So, Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. So either you are diagnosed or have suspected COVID infection and managing well and quarantine or isolated at home. So what are some symptoms that will prompt further evaluation at an urgent care center or the emergency room? If you are having worsening symptoms of shortness of breath, difficult to walk without getting very short of breath, cannot speak in full sentences, chest hurts when you take a deep breath or even shallow breaths, your lips are turning blue, you and your family member notice that you are disoriented, you're not able to eat or drink because you're vomiting or have diarrhea, you cannot keep yourself hydrated. If you're diabetic and your sugars are getting out of control, both high or low, if you have previous organ transplant, you have cancer and you are on chemotherapy, you have moderately advanced lung disease like emphysema or asthma, you should seek higher level of care sooner. You can go to urgent care center or the emergency room or call an ambulance. My bias is that if you are in need of further care, ER will be a better choice. It is very important to inform urgent care and the emergency room about you going there so they can triage you immediately on arrival. Therefore, keep your preferred emergency room phone numbers handy. In case you go to the emergency room and you're sent back home, stay vigilant and do not hesitate to return to the ER if your condition deteriorates or gets worse.
Thank you very much. One of the concerns patients have as they get admitted to the hospital, some patients will be COVID positive and they're getting admitted because of that. But there could be patients who have a stroke or a heart attack and they're worried about coming to the hospital. They're worried about coming there, getting admitted, and now contracting as a secondary infection COVID. Can you tell me, at least from the LGH perspective, what happens to these COVID patients? Do they have a dedicated floor that they go to, and so there's no cross-contamination?
Yes, LGH, we have dedicated floors where COVID-19 patients are being attended, cared, and so the care is very coordinated. All the rooms are private. So they can be reassured that they will be going to a dedicated COVID floors and they will have separate doctors, separate rooms, and separate nurses.
Thank you. And what about family members? Has the visiting policy been changed? Are family members allowed to come to see COVID patients or the non-COVID patients? Is there a different policy now in place?
Yes, for COVID-19 patients, family cannot come and see their loved ones. However, the physicians and the nurses who are taking care of them, they'll be in touch with them and they will update them regularly. If the family wants to stay updated, they can call the nurses. Family can have video calls with the patient. Therefore, always have your family contact numbers ready so that can be shared with the nurses and the physicians so they can reach out to your family members.
Thank you. And if there's a patient now who's making his way or her way to the hospital, to the emergency room, what should he or she be carrying with them in terms of like medication list, allergies? If you could share a little bit of insight what they should be doing at that point.
Yes, so my advice is that once you suspect or have diagnosis of COVID infection, have few things ready in case you will need to go to the hospital. Short list of essential items should be ready in a small bag, which may include contact number for the family members, medication list, maybe a copy of Quran, a prayer rug, phone, and most important, phone charger, so you are not struggling at the last minute looking for all these things.
Okay, and if they have an advanced directive, should they be taking that, finding that, and taking that along with them?
So advanced directive, if they have it written, they can take it with them, but the best thing will be that they communicate to the providers that what would they like to do if the condition deteriorates or they're not doing well. So I think that can change from time to time. So just having a paper advanced directive may not be enough or sufficient because the circumstances change. And we will talk about this further in the course of our discussions.
Thank you. What about the nursing staff? You know, I think one of the things that patients may have concern about is with all this lockdown and social distancing, if I get admitted to the hospital, would there be an inertia of the caring staff, the nurses and other allied staff to come and see me just because I have the infection? Should I be worried about that?
No, as a matter of fact, you will get extra attention because there are more nurses to patient assigned to COVID floors. However, physicians and nurses' contact time or encounter may be shorter to avoid exposure time. I will add that it is advisable for patients to put on their mask when there's another hospital staff member in the room attending to them.
Got you. Sounds good. And you know, this is the month of Ramadan, and some people might be having a fast when they get admitted to the hospital. Can they ask the provider, can I get my medications at Sehri time or Iftar time, and so that I can still keep my fast? Any thoughts on that or any advice along those lines?
Yeah, Shakil. So without getting into the details of the religious ruling regarding fasting, being sick, being in the hospital, I strongly will discourage that you should not be fasting. And inshallah ta'ala, you can make up for your fast later. So my recommendation is that that option should not be on the table, that you should be fasting while in the hospital.
That's great advice. Thank you. When a patient gets to the floor, what are the treatments that you may be offering your patients on the floor?
So if you are found to have low oxygen and require supplemental oxygen, you'll be admitted to the hospital. This indicates that you have a COVID-19 viral pneumonia. Other things will be if you are found to have secondary bacterial pneumonia, you'll be admitted. If you are found to be dehydrated clinically or by lab work, you will be admitted for maybe IV fluids. You may even go to ICU if you need higher flow of oxygen.
Thank you. And you know, one of the things I think patients may be thinking about, because we have a different system now, we have the hospitalist system in the hospital, is if I'm coming to the hospital, can I pick and choose my doctors, or I have to go with the doctor that is assigned that day?
So presently we have a group of physicians who are taking turns to take care of COVID-19 patients. So you and your family member can request a certain physician that you have some contact with, but their role will be just to bridge the communication between the physician, the patient, and the family. So if you have a certain request, please make sure you ask the staff member that you would like this physician to be involved in the care, who will basically advocate for you and will not be actively managing your care, but you have dedicated physicians who will take turns taking care of you.
Thank you very much. Now we are going to go now into ICU care, and Dr. Ahmed, I have a few questions for you. What percentage of patients who actually make it to the hospital or to the floors actually move on to the ICU approximately?
That depends upon the hospital policies and the physician comfort level, whoever is managing on the floor. So whenever they feel like the patient needs ICU, they transfer the patient to the ICU. Or the patient's situation gets worse on the floor, then the patient gets transferred to the ICU. But generally speaking, when the patient gets transferred to the ICU, there are a couple of reasons. It's not only for the COVID, but generally for anything. Oxygen level is going down most of the time, of course, when they get admitted in the hospital. They are on oxygen, especially in the COVID, they are on oxygen on the floor. But if the oxygen level is still going down, let's say they are on 4, 5, 6 liters of oxygen, nasal cannula on the floor, and their oxygen level is still dropping, then that's the time to transfer the patient to the intensive care unit. Or if their hemodynamics is abnormal, meaning that their blood pressure is going down, or their heart rate is going up, or their mental status has changed. So those are the things that needs transfer to the ICU.
All right. So I just got a call from the attending physician about my loved one going to the ICU, being transferred to the ICU. Does that mean that that person is going to die?
Not necessarily. ICU care means that you need higher level of care, meaning that they can monitor better. They have one-to-one nursing care. So level of care is much higher as compared to the floor. It does not mean that everybody goes to the unit has to die. It's just the level of care, because the intensivist is there. Nursing care is better, and they have more tools in the ICU to manage the airway, to manage the hemodynamics, to take care of the blood pressures, heart rates. Those kind of issues are better managed in the intensive care unit.
Yeah. So Dr. Ahmed, when you receive a patient in the intensive care unit, there are certain procedures that you sometimes offer to your patients. So I was just wondering if you could just give a little bit of an insight as to some of the procedure that gets done in the intensive care unit, so our audience out there will know what they can potentially face, or whatever recommendations can they'll be facing when their intensivists talk to them about these procedures. Some of the procedures, if you could just sort of enlighten the audience with.
Yes. So as I said, we are talking about COVID. So majority of the reason the patient gets transferred to the intensive care unit is the respiratory status, the oxygenation is the issue. Then the intubation is one of the commonly performed procedures when we talk about the COVID, because their oxygen level is low. And first we try high flow oxygen, just like a nasal cannula, but with a high flow to improve their oxygen level. But if the oxygen level does not get better, then those patients needs endotracheal tube. Or if the patient is struggling for breathing, that's also an indication that the patient needs to be intubated. So that's one procedure. The other procedure, once the patient is intubated, most of the time they are on multiple medications. The medications to keep them calm. The pain medications, they are on different antibiotics, different drips, the IV fluid. So they need a different, bigger line. The catheter, most of the time we put on the side of the neck to give all the medicines. And the one catheter usually goes in the arm just to monitor their blood pressure directly, as well as to take the samples, because we need their blood work on daily basis. We need to check their blood gas a couple of times. So those are the commonly performed, but other procedures depending on their kidney functions, liver functions. Let's say if somebody comes to the unit, primarily came initially for breathing problems, but got complication. The renal functions are not better. The urine is the patient is not making urine. Then we have to put the dialysis catheter also. So those are the commonly performed procedures that we do in the ICU.
Got you. And do patients in the intensive care unit, do they get fed? Is there, how do they feed them?
Yes. So when we intubate the patient, at the same time, we put the tube through the nose into the stomach to feed them.
Okay. And when they're on a breathing machine called a mechanical ventilator, are they awake or are they allowed to sleep?
No, once the patient is on mechanical ventilator, we make sure they are comfortable. We give them the sleeping medicines and the pain medicines to make sure they are sleeping, they are not in pain, and they are not in distress, because having the tube in the throat is not very comfortable feeling. So we make sure that they are very comfortable.
Thank you. And one of the things that sometimes they might have read online is about the heart-lung machine, or the ECMO, extracorporeal membrane oxygenator. Can you tell us something about this? And is this for every patient, or is this for some patients may not be a good candidate for this?
Yes. So first we tried the other things like, as I said, high flow nasal cannula, to give the high flow of oxygen. We prone the patient because the proning also improves the ventilation on the posterior side of the lungs. and then the mechanical ventilation. We can do some procedures on the mechanical ventilator to open up the lungs more, just to increase their oxygen level. And sometimes we have to paralyze the patients. We give them the paralytic medications just to decrease the oxygen consumption as well as to decrease the carbon dioxide production. But if nothing is working, then ECMO can be used as a rescue thing. Most of the time, it is for the oxygenation issue, but sometimes if the patient hemodynamics is not under better control, if they have low blood pressure along with oxygen issues, so with the ECMO, we can also take care of that issue also. But not everybody is a candidate for ECMO. There are some absolute contraindications and some relative contraindications. Absolute contraindication for ECMO is if somebody has a disease that has no cure, like very advanced cancer, those patients usually are not candidate for ECMO. Or if somebody has very severe brain injury, so there is no beneficial outcome, so those are not the good candidate for ECMO. Relative contraindications, if there is uncontrollable bleeding, that's one of the relative contraindication for ECMO.
Thank you. So there are, and we, as many of the panel members today have already said, that there is no specific targeted therapy to the SARS-CoV-2 virus, but there are certain therapies out there that are being offered. You know, we have the tocilizumab, we have the convalescent sera, we have also remdesivir. Can you these are probably some of the things that may be offered to the patients' families, for the patients. If you could shed some light on those therapies.
Yes, so as you said, there is no definite treatment. These are all just the potential treatments. So hydroxychloroquine is there, remdesivir, IL-6 inhibitor is there. So these are the medications are being used at this point, but should be used at the right time. For example, hydroxychloroquine, it blocks the attachment of the virus S protein to the membrane. So theoretically speaking, should be given early in the disease process. Although initially there was a recommendation to use on every patient, but it is actually falling out of favor more recently. Then remdesivir has shown some benefit in US trials, but although in the Chinese trial, they did not show much improvement. But in the US trial, they said that it has decreased they actually enhanced their recovery time from 16 days to 11 days. So what remdesivir does, remdesivir actually enter the virus RNA and blocks their replication. So again, theoretically speaking, should be used early in the disease course. Then we have IL-6 inhibitor like tocilizumab. This is, it blocks the inflammatory pathway because for some reason, these patients have very, very high inflammatory markers. We check their inflammatory markers on daily basis. We check their ferritin level, D-dimer level, and the CRP, LDH. These are very high in these patients. And tocilizumab, IL-6 inhibitor, can block the inflammatory pathway, and it has shown some improvement in these patients.
And the convalescent sera that...
yes, convalescent serum also is being used. Basically, this is giving a passive immunity to these patients because these already has antibodies from someone who was infected with COVID and managed to make some antibodies. You are injecting those antibodies to the patient, and that also helps.
Thank you.
And along with that, we also cover like superadded infection, like pneumonia. We always cover with other antibiotics just to make sure the patient does not get other infections.
Got you. And how long do these patients stay in the ICU? Is it variable? Do we have people who stay a short period of time, people who have a lengthy stay in the ICU?
Shkir, this is, for some reason, these patients stay in ICU and stay on vent much longer than the other ARDS patients, the respiratory failure patients. In other respiratory failure patients, most of the time, after 3-4 days of mechanical ventilation, you are able to extubate those patients. You can take the tube out. But for some reason, the COVID patients, they stay on vent for much longer time to recover.
Gotcha. Sounds good. And family members, are family members able to come into the intensive care unit, or are they, and because of what's going on right now, are they told not to come to the ICU? Or?
Yes, so they are not encouraged to come to the ICU just for their own safety as well as for the safety of the staff. We can arrange the video calls where they can see their loved ones, but we update them every single day. They can call the nursing staff, they can call the physicians, and we give them the up-to-date every single day. They can call us multiple times, but we usually discourage the families to come to the ICU.
Thank you very much, Dr. Ahmed. And for the audience out there, if your family member has gone into the intensive care unit, make sure you find out which ICU they are in, which bed they are in. And sometimes some ICUs have a passcode that they will give the medical information only to those family members who have that passcode. It's also easier for the intensivist if we have one designated family member to bridge that gap, who is the liaison between the team providing care and the family member, rather than having different family members. It actually, when you have different family members, it sets the stage for miscommunication. So if you can identify earlier on within your family someone who is competent, someone who understands, who has a good insight as to the medical aspects of care, you should designate that patient and have all this information handy so that you have a person who's designated to be the liaison between the intensivist and the intensivist team and the family member. Changing gears now, we're going to talk a little bit about pregnancy and children. Dr. Syed, my next set of questions will be actually coming to you. If we have a pregnant person, and what precautions should they be taking during pregnancy? What are antenatal visits? Are they happening now, as we have heard many practices are not seeing patients physically? I think we'd have to unmute the mic. Oh, there you go.
Assalamu alaikum, everybody. Thank you for having me here as a panelist. So of course, the COVID-19 pandemic has prompted changes in the OBGYN world as well. And this is all, of course, to protect the health and safety of both the mother and the baby as a unit. So as far as what precautions should a pregnant woman take, those precautions are not different from any non-pregnant individual. So the recommendation is to follow the CDC guidelines, use measures like hand washing, hand hygiene, social distancing, anything that with the previous panelists have talked about, and follow the CDC regulations with regards to that. In terms of the antenatal visits, there are, telemedicine always existed for years, but now it's in full force, and the OBGYN world is using that really very effectively. So the patients need to know that some of their visits could be converted into telemedicine video visits, and that has been working really well for us. Most of the care provided during pregnancy in all trimesters, in the first, second, and third trimester, can be pushed out for at least a couple of weeks until the infectious period in any possible COVID positive patient can be transitioned. So it is not unusual to postpone those visits for at least a couple of weeks. It also, even in patients who are COVID positive, it just doing the telemedicine visits really helps us to check on these patients and to see how they're doing. Are they getting worse? Are they getting better? Or are they remaining stable? And it will depend on the offices. Some offices have a strict policy, but in obstetrics, it's hard to have a strict policy about what gestational age a patient should be coming in and so on. So really, it's a communication based on the patient's risk factors, on the condition of the mom and baby, and what is safe to do in terms of postponing these visits. Same thing goes with ultrasounds and other appointments. We do limit visitors. We do COVID screening both before they make an appointment and at the time they arrive to the office as well. So limiting visitors, wearing masks, all these are measures to promote their safety.
Thank you. In terms of the diagnosis of COVID in pregnancy, when it's established earlier on in pregnancy versus later on in pregnancy, are there different implications of that earlier on and later on?
So this is an area where we do not have enough evidence as of yet. As you can imagine, there are data registries which are tracking these effects, but in general, right now, there is no incidence of congenital anomalies or miscarriages if a patient was to get COVID-19 in the early part of pregnancy.
Gotcha. Okay. And later on in pregnancy, if they're diagnosed with COVID, does it impact delivery, things like that?
So actually, the way we look at a pregnant COVID positive patient is, again, depending on the severity of their symptoms. Just like our ICU docs have outlined, saying there is, depends on whether the patient has mild, severe, critical illnesses related to the COVID-19. But COVID-19 by itself is not an indication for delivery. Having said that, patients can have preterm births. There is no other there's no other complication related to just pregnancy itself. The delivery would be for obstetric indications only.
Thank you. And the other question that you have is vertical transmission. The transmission from a mother to a fetus while the fetus is in utero. Where are we with that? Do we have any understanding where things are along those lines?
So theoretically, yes, vertical transmission can occur because the SARS-CoV-2 receptor is present in the placenta, it's present in the fetal lungs, so it's present in the membranes that surrounds the pregnancy. So theoretically, yes, but in the limited evidence that we have, the babies have tested positive for the antibodies, but again, they are not very symptomatic, thankfully. So vertical transmission is not that common, but again, this is in light of the very limited evidence that we have right now.
Thank you. And if a mother who is COVID positive has just delivered in the hospital, is she allowed to keep the baby in the hospital, or do they have isolation between the mother and child?
So and this is a COVID positive patient, the recommendation is for separation of mom and baby, just to reduce the baby being affected, because as we discussed, this is through respiratory droplets, and because the mom and baby are going to be in very close proximity, it's almost impossible to prevent that unless there is separation or isolation. We try our best to keep the baby in the room just as adjacent to the mom, but they can refuse, they can decline, and they can keep the baby in the room as well. But at that point, then we would recommend that they definitely wear a mask, they use hand washing hygiene and general procedures before breastfeeding and before every feed. And if they decide to have the baby in a separate room, then we make sure that they can breastfeed, they can pump, and that breast milk is then provided to a non-COVID positive family member who can then feed the baby. So they're definitely allowed to decline the separation, but the recommendation would be the separation.
Thank you. And the physical process of actually physically discharging the patient home and the baby home, do they hand over the baby to the mother, or do they need to have other family members to be there to make this process happen?
So typically, it depends on the hospital setting, but usually one family member or visitor is allowed as a support person throughout the labor and delivery process. And depending on the maternal condition, it would be the family member who would take care of the baby primarily. If they're isolated in the hospital, it makes sense to continue that isolation at home. But if the mom and the baby are not isolated in the hospital, then really the mother can take the baby home and carry on with the general precautions.
Thank you very much. We're going to move on now to questions relating to the child and children. This is questions for Dr. Vinitha Manula. Vinitha, can you shed some light on the symptomatology or the symptoms that a child can present with? And does it vary from the way adults are presenting with COVID-19?
Assalamualaikum, everybody. Bismillahirrahmanirrahim. So children are presenting a little bit differently. A lot of children are actually asymptomatic, which means that they may have the virus, but they don't present with the cough or the fever or the vomiting or the diarrhea, which is very important in terms of disease transmission because they don't appear to have the infection, but they can very well pass it on to whoever's they're in contact with. On the flip side, there are kids who do present with fever, cough. A lot are actually presenting with GI symptoms like vomiting and diarrhea. And some are presenting with rashes. There's a new term called COVID toes, where there are these darkish discolorations on toes and fingers that we're seeing in some children who are COVID positive.
Thank you. And what should be the impetus for a parent to call the pediatrician or take the patient to the hospital?
So when children are sick, especially younger children, 5 and under, and especially 1 and under, if there is a high fever, anything above 100.4 degrees is considered a fever, then they should give them something for the fever, call the pediatrician, let them know what the symptoms are, and they will give you guidance as to what you should do further. If those symptoms then become worse, let's say the child is vomiting and not able to keep anything down, or is coughing or having respiratory distress to the point that they're not able to speak or not able to drink their formula, or they appear to be in distress, then that means that they need to be seen urgently. So monitoring symptoms is very important in this.
Thank you. And what about well-child visits, vaccine visits? Are they still happening?
Yes, they are. Well-child visits, especially under the age of 2, where the majority of vaccines are given, are very important because we need to make sure that after the COVID is under control, that we don't have another pandemic of vaccine preventable diseases. So most offices do have well-child visits going on right now. A lot of things are being taken into consideration. We have separate waiting rooms for children who are coming in for well-child visits. There are separate exam rooms that are being used for this purpose. And we are decreasing the amount of time that they are spending in the office. Patients are allowed to call from their car, and the nurse will go out and get the patient and bring them in. Everything is being done for the safety of the patient and the safety of the staff. And while in the office, children above 2 and their parents are asked to be wearing masks to keep everyone safe.
Good. And now in the home stage where as Dr. Syed was saying, patients get, once they get discharged from the hospital, the mother and child, when they come home, some of the questions that COVID positive mothers may have is breast milk and transmission of COVID, and how they can actually continue to breastfeed their child at home, and also maintain that safe distancing with their child. How can they go about doing that when they're physically breastfeeding a child?
So, breastfeeding, if the mom has decided that's what she wants to do, is an excellent way of feeding babies and should be continued. As Dr. Syed had mentioned, making sure that they're decreasing the risk to the baby by hand washing, by wearing a mask at all times while they're feeding, and washing before and after the feeding happens. But if a mom has decided to breastfeed, that is very good for the child. I'm not aware of any reports of COVID being transmitted in the breast milk, but there are many other immunological properties of breast milk that make it very beneficial for children. So if mom wants to do that, then they should do it. Just follow the precautions.
As a parent with multiple young kids, how do we go about actually ensuring physical, distancing between the siblings? It's probably going to be a challenge with young kids. So do you have any tips for parents who have one child tested positive for COVID, or they have been tested positive with COVID?
It's very difficult, especially when you have toddlers, to keep them separate. So basically what we're saying is to, wipe down everything, the doors, the handles, the bathrooms, the toys, everything that's being used, frequently, to use your antiseptic, your washes and your wipes to make sure they're as clean as possible. Try and keep them as separate as possible, but when you're in the same family, it's very difficult to keep them separate. So, try your best with the hand washing and the separation, but, and if the other child does get it, then we just monitor as we would. But again, it's very hard, especially if someone's living in an apartment or a smaller space, to keep children away from each other, unless you're going to send them somewhere else, but then you're putting the other people at risk as well. So it's a very difficult decision, but each family has to make those decisions on their own, depending on what their situation is.
Thank you. Similar to the question that was asked to Dr. Hafiz, if there are children being admitted to the hospital because of COVID, and the children admitted to the hospital for other reasons, as a parent of a COVID positive child and a parent of a COVID negative child, one of the concerns that may be there with a lot of parents is, my child is sick, but I just don't want to take them to the hospital because I'm concerned that they may now get the COVID infection. Is that a genuine concern? Should they be, is there anything you can do to tell them that it is, it's okay, or what should they be doing?
So if your child is sick and needs to be in the hospital for whatever other reasons, children get appendicitis. Now children are home 24 hours a day. The number of traumas that we're seeing has skyrocketed. Broken hands, broken fingers, needing surgery for those. So those are unavoidable. The hospitals are doing everything that they possibly can to keep children and adults safe from this infection. There are isolation units, isolation rooms for patients who are COVID positive. So, the hospital staff uses the proper protective equipment between patients so that they're not transmitting the virus from one to the other. So there will always be other reasons for coming into the hospital. Sometimes there are asthmatics who are having acute exacerbations and need to be in the hospital, not COVID related, but they need to be seen and they need to be taken care of. So yes, I understand the fear, but parents should understand that everything is being done to try and mitigate the risk to children and families when they're needing to be in the hospital.
What about parents? Are parents allowed to stay with the child in the hospital? Can they visit their children? How does that process work?
So every hospital system is going to be different. And so some hospitals are allowing one parent to stay with the child. That also depends on if there are COVID positive patients at home, if there's been a risk of, coming in contact with someone who had COVID. If any of those arise, then no, they will not be allowed to be with the child. But under most circumstances, they will try their best to have one parent be allowed to stay with the child.
What are the treatments that are being offered on the floors in the hospital for children?
Pretty much what the speakers had mentioned about for adult patients. Basically, it's just supportive care at this point. Fluids, IV fluids for maintaining their fluid status if they're vomiting or having diarrhea, oxygen if they need that for their respiratory status. and the antipyretics for fever are some of the mainstays of treatment right now.
Sounds good, thank you. And what about a child? If a child gets, if their parent gets a call from the floor saying that their child is being transferred to the pediatric intensive care unit, does that mean that their child is going to die?
Not necessarily. As mentioned before, it just means that they're getting a higher level of care. So I would tell any of my patients that if that were to happen, that means that you're going to have more people watching your child at a much more intense care level. So they're going to watch their breathing, they're going to watch their fluids, they're going to watch their fevers, they're going to watch how they're eating a lot more than if they were just on the floor. So yes, it's a scary proposition, but it just means that they're going to get a higher level of care.
Got you. One of the things that we are hearing about recently is that Kawasaki syndrome. We are also hearing about the pediatric multi-system inflammatory syndrome, PMIS. Can you shed some light on this?
So it's an inflammatory syndrome that we are seeing now with COVID-19. We had seen it previously. It's more of a range of symptoms. Children are presenting with conjunctivitis or pink eye. Their lips get cracked. They have a strawberry appearance to their tongues. Their lymph nodes can get enlarged. They can develop rashes and very high temperatures. The issue with this is it's an inflammatory syndrome that can affect many organ systems. So it can affect their heart, it can affect their intestines, their stomach, their pretty much anything in the body. So there have been reports from the larger cities. I believe New York had about 110 cases till now. And again, patients will be monitored in the ICU, and supportive care will be given, usually with intravenous immunoglobulins, IV steroids, and maintenance support.
Thank you very much. We are now moving on to the last leg of this roundtable. We are going to switch gears now and go to talking about complications. I would like to bring Dr. Ahmed, if you will, and tell us about some of the complications that can be encountered in the medical intensive care unit.
So complications could be the equipment related that we used in the ICU and could be disease by itself. So when I say equipment related, as I said before, when we put endotracheal tube to help breathing, that carries a risk of complication right there, because when you have the tube in the throat, there is a risk that the secretions from the mouth can trickle down into your lungs and cause infection. We call ventilator-associated pneumonia. So that's one thing. And then I said when the patient's in the intensive care unit, because they're on multiple medications, we have to put a catheter on the side of the neck to give all those medications, so that catheter can get infected and cause infection there. Then there are some ventilator associated complications as well, because it's the positive pressure you are giving in the chest. And in the COVID patients, if the inflammation and disease is not getting better the way you want, and with time, the lung tissue gets fibrosed, get more hard, in other words. So they are not very compliant anymore. Then there is a risk of causing pneumothorax and barotrauma. So meaning the lung can collapse, and then you have to put the chest tube to open up the lungs. Then there are some disease-related complications. This disease, these patients have very carries a high risk of blood clots. They make clots more than we see hypercoagulability, meaning the blood can get thick in other conditions as well, like ARDS, respiratory distress syndrome. But these patients have much higher risk of making blood clots. We are seeing patients with the COVID getting blood clots in the legs, blood clots in the lungs. They can get heart attack from the clots. They can get stroke from the clots. So those are other complications from the disease itself. And sometimes also the kidney injury. kidney injury, renal failure in these patients could be from multiple reasons, could be from disease by itself, in a lot of inflammation, oxidation in the body, and maybe it's a fluid status because they can get hypotensive, blood pressure gets low, and the kidney perfusion gets low. Maybe that also plays a part. But the blood clots also is playing a role. So these are the couple of the complications that we see.
Thank you very much. And Dr. Giva, when patients in the ICU, are you seeing, besides the COVID-19 infection, are you seeing other infections also in the ICU in these patients?
Yes, I am. So just like most patients that are hospitalized for prolonged durations, COVID-19 patients are similar in that sense. So they are at risk for hospital-acquired infections. And the common ones are the secondary bacterial infections, secondary bacterial pneumonia, which you would see following flu, and we see that with COVID-19. And more so for patients who have received the IL-6 inhibitor, tocilizumab or Actemra, because it kind of decreases your immune system. So they're more likely to present with hospital-acquired pneumonia and ventilator-associated pneumonias. So also other hospital-acquired infections would be UTI, because again, most of these patients would have a catheter in, so catheter-associated UTIs can happen in these patients. But overall, just Dr. Masood had mentioned, the majority of this of the complications are respiratory related, so the ARDS, the severe pneumonia, and then multi-organ failure, as he had mentioned.
Thank you very much. So patients do get sick in the ICU. Patients do succumb to this illness, and sometimes families have to maybe faced with this situation as to the complex situation of what's happening with their family, the loved ones in the ICU. So my next set of questions will go to Dr. Saraj. Dr. Saraj, can you tell us something about, there are times when the ICU team may be getting in touch with family members and talk about palliative care. And can you shed some light on what is palliative care?
So thank you for giving me the opportunity to talk about an important aspect of the care of these patients. And as my colleagues would agree, we know that the majority of people who become ill recover and go home and do better. But unfortunately, there are the minority who don't do well, and where a different type of care needs to be involved. So what is palliative care? Palliative care is comprehensive care that's focused on alleviating suffering and providing comfort at end of life. Unfortunately, there is a population that has been harder hit with this illness, and that's the frail elderly. Palliative care tries to identify which patients would benefit more from continuing care with comfort as a primary goal and without the use of artificial means of respiratory support through a ventilator or other heart and lung machines. And the palliative care team, which is made up of medical providers, social workers, and chaplains, they're called to facilitate discussions about prognosis, treatment goals, suffering, and resuscitation.
Thank you. And Dr. Saraj, how does palliative care differ from hospice care?
So palliative care is care that's provided in a hospital setting, and hospice is provided through an agency, generally outside of the hospital setting.
Got you. And is there also an aspect where we can render that hospice care in the hospital setting itself, or?
And depending on the community, there are occasions when hospice can come into the hospital and provide some oversight and assistance to the care that's being provided by the general medical team.
Thank you. Will someone call the family and keep them posted as to how patients are doing in the ICU, especially now when family members cannot come in? How does that process work?
So anyone in the medical team may call the family to give them updates. And oftentimes it's the patient's nurse that calls with daily updates. Sometimes a primary physician or one of the specialists, and even a palliative care team member may get called to keep the families posted on what's happening.
Thank you. I know you spend a lot of time with palliative care and hospice in the ICU. Who is the power of attorney? Can you shed some light on that?
Sure. So a healthcare advance directive is a legal document in which people specify what actions should be taken for their health if they're no longer able to make decisions for themselves because of illness or incapacity. A healthcare power of attorney is someone that we designate as our decision maker in a situation when we can no longer make those decisions. The advance directive can be downloaded from the internet, or you can get it from your doctor's office, or even an attorney.
Is that something good to have prior to going into the hospital?
Absolutely. I think it's an important thing to have for anyone, kind of like a will where you prepare a financial will. A healthcare directive is also important to have on hand. It may be a good idea to have a healthcare directive that is for COVID sort of situations, and another healthcare directive for non-COVID situations. And something that generally we should kind of think about when we're not in a crisis or in a difficult situation or in a hospital setting, and relay our wishes to our family members or people that we trust and want to be there and make those decisions if we can't speak for ourselves. However, it can also be done in the hospital setting, and sometimes on admission, and even in the ER when someone presents, that question is asked, and sometimes those decisions have to be made at that time.
Thank you very much. And then if a family member gets a call that their ICU team is recommending a do not resuscitate, what does that mean? And can you walk us through the process?
Sure. So there are a number of designations that are used in the hospital setting, and they refer to use of technology and treatments that are used to resuscitate the heart and potentially prolong and sustain life. So a full code means that in the event that one's heart stops working or you're found to have no pulse, the healthcare professionals will start chest compressions and or administer an electrical shock in an attempt to resuscitate the heart. So this can be accompanied by putting a tube down one's throat that connects to an oxygen machine for mechanical ventilation, and that's known as intubation. There are other designations like a partial code, which may include some of these measures, but not all. A no CPR would mean no chest compressions. A do not intubate would mean no use of ventilators, and no defibrillators would mean no electric shock should be applied. So it's important to have a conversation with your doctor who knows your health, who knows your health condition well, who can guide you on which of these modalities may be reasonable and beneficial for you.
Got you. And if my loved one is made a do not resuscitate, does that mean that there's going to be an inertia in treating those patients? Will they be getting suboptimal treatment?
So that's a great question. The code status becomes relevant only when someone's heart stops. So a DNR status doesn't change the way someone would be cared for otherwise. All other care would be the same. If a COVID patient whose respiratory status deteriorates chooses to not be placed on a ventilator, choosing a DNR status, care can still be continued and with comfort as a primary goal. There are a number of instances when not going through or not having a ventilator support is the best form of therapy and the best decision.
how do we make that decision from the patient's end as to whether I should be making my loved one a do not resuscitate or not? Have you got anything that could help me make that decision? Because this is a very difficult decision, and especially when things happen very fast, it may be difficult for some family members to actually know what is best for their family members. So is there something that you can help us build our decision making on?
Sure, it's important for anyone to really truly understand their health condition, to understand their prognosis and what the outcomes might be if a certain form of therapy was pursued. And once they have a better idea of what may be expected, then the decision to pursue a certain type of therapy or let it go would be easier. So collaborating with your team, making sure that you truly understand what's happening and what your options are, and knowing what your goals are, what your wishes are for your care, are important aspects of this decision.
Thank you. Dr. Saraj, what if a family's spiritual inclination or cultural inclination is such that they want to continue everything? Would that decision be respected by their team?
Sure. So the decision to pursue a certain level of care should be made by the patient in collaboration with their medical team. So if you have some strong preferences and believe that you must pursue a certain course to be in line with your spiritual inclination or cultural practices, then that's an important conversation to have with your medical team so that they can honor those wishes. And you and your medical team can work towards a better understanding and a common goal if they know your values and your preferences, and if you understand your condition and options well.
Okay. And Dr. Saraj, if for Muslim patients, can they request imam to come in, and how does that process work? If you could walk us through that.
Sure, absolutely. And every hospital may have some different policies or different practices. But the one that I'm best familiar with, I understand that the chaplains are called to facilitate the call to the imam or the Islamic center. So they will call the local Islamic centers and request an imam.
Thank you. And for the audience out there, I know these are very difficult topics that we are bridging right now, but if you do have any questions, please chat with us on Zoom and we can bring it to Dr. Saraj. Thank you very much, Dr. Saraj. I'll be asking the next question to Dr. Babar. Dr. Babar, unfortunately, people die from COVID. And when a COVID positive person dies, what happens to what's the process in the hospital in terms of how the body moves? Do they go to a different morgue? And what happens also if a COVID positive patient dies at home? Is the process different? If you could shed some light on that.
Sure, Shakil. So, as Surya was sharing, that if patient is not doing well in the hospital, very early we start engaging with patients and the family about discussions of what we call end-of-life care. With the visitors restriction, most visitors cannot come to the COVID floors. However, these are extraordinary circumstances where their loved one is dying. So hospital does allow up to 2 visitors for a patient in a COVID floor in that case. Much can be done via remote as well. So unfortunately, if a patient dies, the patient's body is covered, and extra covering is applied compared to the usual process we have for other patients. For COVID patients, we have extra covering to protect the infection spreading elsewhere, and then their body is handed over to morgue. And in the morgue, based on religious affiliations or cultural affiliations, body is kept for 1 day, 2 days, or several days, and then it is sent over to the funeral home for burial or cremation. A very similar process is for home. Home, usually, as Sister Priya was sharing, hospice is involved, and they communicate very well with the morgue and the funeral homes as well. Just for the statistics, in Lancaster County, we have around, as I shared earlier, 247 deaths 75% of them are actually have the deaths were in nursing home. And geriatrics program and palliative care program in the community have done very good job by appropriately, having advanced care planning discussions in the nursing home, so hospital is not overburdened. In hospital, we had 24% of the deaths, and only 1% of the deaths in the community in Lancaster are at home, but the process is very similar. In the funeral home, I should share that there are some restrictions. Again, proper protection equipment is used by the family if they attend the funeral of their loved one. They have restrictions up to, it's my information, that up to 10 people can attend the funeral, not more. And they have to keep the distance 6 foot apart, and they cannot go close to the body. They can have the viewing, but that's the process of the funeral homes.
Thank you very much, Dr. Baker. We're coming to the final set of questions, and these questions are for Brother Mukram. Brother Mukram, can you tell me, can you share with us what happens from the body once the body leaves the hospital? Does it go to the funeral home now, or how are we coordinating that process?
So, so far in Lancaster County, right, so all the COVID-19 victims' bodies are brought to funeral homes. So the hospitals, or from home or hospital or nursing homes, they can be brought to funeral homes, and from there they are taken to the cemetery. And the body is placed in a plastic bag from the hospital, and then again even for the burial. So there will be a plastic bag, body bag.
And what about the body washing process? Can you tell me how that is shaping out now?
Okay. Think so. At present, with the use of proper PPE, personal protective equipment, a normal body as well as a COVID-19 body both can be washed at a local funeral home. Okay. But what happens is the PPE equipment is not enough at the funeral home. So, and the other thing is they're only allowing 2 people to wash the body. Okay? Having said that, we don't have any professionally trained Muslim male or female persons to wash a victim, a COVID-19 body victim. So we at Lancaster, because of the size of our community, we don't have a Muslim funeral home, nor we have any volunteers who are properly qualified to wash a COVID-19 victim body. So we are going to rely on the Fiqh Council fatwa, which is pouring the water over the the body, and also doing tayammum, and it also allows us to use tayammum, but we can also choose either way. Having said that, like Manham Township here especially in Lancaster County has been affected a lot. We do work with a couple of funeral homes, but I'll come to that a little later. But the whole what I'm trying to say is we had no Muslim COVID-19 funeral in Lancaster. So Alhamdulillah, I know there are some community members at the hospital, even at ICU, at both the hospitals here, but we've had no Muslim death related to COVID-19 to our knowledge in the last 2 months. In fact, in the last 2 months, we basically witnessed two deaths, one of a elderly male and then a young lady who died of cancer related or some other medical issues, but none of them had COVID. So Alhamdulillah, so that's where we are. But when it gets to the if we have a funeral, we are prepared, but then we don't have someone who can wash the victims.
Got you.
We would use the fatwa, and then we'll use the tayammum. Go ahead.
Got you. Sure. Thank you, Brother. So coming to the last question here is, can you share with us what should a family member do when they know that their loved one has passed away? When should they be calling? Should they be calling at the time, they pass away, before that, when they have an inclination they're not doing well? What happens also if that patient is not from Lancaster, but from the nearby area, or someone from Lancaster? What should be the process that ICCL is encouraging?
See, that is something like, every individual should be planned for. Like, they should discuss what happens. The family should be ready. I just mentioned, like, for body washing, like, we rely on volunteers. So a lot of time those volunteers come from outside the family, like, so the family many times is just mourning and, like, grieving and, like, stays on the sides. No, I think people should not wait for them to end up in ICU. They should plan that, like, they should talk to ICCL, and we will guide them to the area, funeral homes and the cemetery, or what the procedures are. And then, and we have agreements. We have made these people aware about the requirements of a Muslim funeral. But I think they should, even COVID or non-COVID, I think, every community member should prepare for their, journey hereafter.
Sounds good. All right, excellent. Thank you very much. So now we will be opening up the floor to questions. We do have some questions out there that has come to us. I will start off for the first question. There's a comment with the first question. It says, wonderful panel, mashallah. Thank you very much for that. The question is, can you please provide some insight regarding gatherings and school reopening? Can we assume that schools will be closed in fall due to a waning of immunity and a predicted second wave? Would love to have an infectious disease specialist input as well. Thank you all. Fantastic group, mashallah. So I will be sharing this question with two panel members. I will share the question with Dr. Babar as well as Dr. Giva. Any one of you can take first dibs at it.
All right.
So regarding, go ahead. What should I say?
All right, thank you. So there's a lot of infectious disease modeling going on regarding how long and how many waves, how many years it's going to last. And they vary. There is a group out of Harvard. There's one in the UK. I think there's one in Germany. But they're varying in terms of how long this is going to last. Is it 18 months? Some say it's going to last for years. But the point is, it's going to be difficult for me to tell you that school is going to be closed in fall. The CDC has done something really great in terms of coming out with an interim guidance for schools. So they have made the guidance, it's very detailed, so it's there for schools to help them decide when the time comes if school is going to be closed or open. And kind of a brief summary of that guidance, it's kind of classified into if there is mild or moderate transmission in the community. So when school opening gets closed, we would have to assess the community transmission, what it is at that time, like maybe a month before or a few weeks before school is supposed to open. Is it mild to moderate, or is it substantial? So the CDC has a guidance based on that. So if it's substantial community transmission, they're tending towards maybe you should extend school closures. But if it's mild, then you could open, but with very strict and stringent processes, like making sure that the cleaning is more intense in terms of cleaning surfaces. And we know children, their hands are all over the place. So they put in that guidance in terms of making sure that they have a process in place for disinfecting all surfaces, and also how they get into school. So if there's a community transmission, just like what we're doing in the hospitals where we're screening patients at the entrance, then that will be expected in the schools as well, where they have screening questions for COVID-19, asking the kids, have they had that? And probably they might even consider checking for a fever when they come in. And also those kids that come on the bus, kind of how they come in. All of that will come into play. How they space their tables in school. So that is really detailed, and I think that they've done something great in terms of looking forward. In fact, they also have a procedure for childcare that stays open, because those childcare are available for those of us that still have to work and the kids go to childcare. So they have a process in place for that. So that will be decided then. Hope that helps.
Thank you very much. Dr. Babar?
Yeah, I will just add a few more words. So in terms of gatherings, still Lancaster, we are not allowed to have more than 10 people in any event because we are still in a red. And that is going to matter when gathering or school question comes up. As Sister said, if we are still in a red, most likely school will be delayed. But if we are in the yellow, most likely school will be opening in the fall or in green, especially. Again, I shared earlier that for the people who joined maybe later, if there are less than 10% tests which are positive in a community, or less than 20 patients per day positive, that means you are going in the right direction. We heard the good news about Pennsylvania. Governor announced on Wednesday that Pennsylvania will receive around $523 million or so just for the school fund from Fed government, which was very good news. So this will be used on the personnel training in the schools, technology purchases, sanitization, cleaning, after school programs, mental health support, which is needed in the school setting as well. So that would be very good. But as Sister shared, this has to start with all the precautions we need. Thank you.
Thank you very much. And the last two questions I have, they're very similar, so I'm going to combine it together. There's a comment also, thank you for this discussion. Can you clarify if I can walk in the park, and if I do so, do I need to have a mask on? The other question is, question from Facebook. So I think these are two different questions. So Dr. Giva, can you sort of share a little bit insight into that? Can we walk in the park? Do I need to have a mask on?
All right. When we're walking in the park, again, we have to remember that a lot of people will be going to the park. So it depends on what time of day you are there. If it's a time of day when there's not a lot of people and you have your mask off, I think that should be fine. But again, depends on how many, if you have people, multiple people coming and going in the park, then you should have the mask with you and put that on once it begins to, you begin to see people around you. Because again, we're trying to reduce the spread, and it's ultimately about being around people. So if you're in the park by yourself, then it wouldn't really matter much if you have the mask on or not. But if there's a lot of people, then you should keep your mask on.
Thank you very much. The last question will be directed to Dr. Syed. The question is, are women considering delivering at home to avoid COVID-19 exposure, and is that safe?
So we are in a unique setting because Lancaster County is, as it is, the home birth capital. So there are already a lot of home births here. But I think that was more of a knee-jerk reaction with many pregnant women with COVID-19 exposure risk. But overall, the recommendation from all organizations related to OBGYN state that hospitals and birth centers are the licensed and accredited institutions and are definitely the safer option for delivery for mom. So the recommendation is to go to the hospital, not deliver at home.
Thank you very much. Well, we have come to the end of this roundtable. And I hope, thank you for being with us today. I hope you found this program to be helpful. I would like to also thank, I know some of the panelists today were actually working and was able to attend this. So thank you very much. I would also like to remind the audience out there that we will be having another program that will be the psychosocial aspect of COVID-19 in the community. We'll be talking with a psychiatrist as well as Islamic scholars, bringing them together, understand it from the Islamic perspective, but as well as from the psychiatric perspective with an Islamic inclination towards that. So stay tuned. We'll be announcing that shortly. Before we end this program, we'll have a short dua by Brother Ahmed, a small prayer. Brother Ahmed, if you could share a short prayer with us.
Of course, inshallah. Thank you so much to all of you for sharing your insights with us. Bismillahirrahmanirrahim. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الصلاة والسلام على الأنبياء والمرسلين وعلى آله وصحبه وسلم. We pray that Allah subhanahu wa ta'ala allows us to keep our hearts and our bodies sound and healthy. We pray that Allah subhanahu wa ta'ala, Almighty God, allows our communities safe, allows us to be safe and healthy in our communities. We pray that Allah subhanahu wa ta'ala keeps all those working for our communities in warehouses, in distribution centers, in the healthcare settings, all of you and then many others safe and healthy. We pray that Allah subhanahu wa ta'ala, Almighty God, will allow our communities to come out of this calamity stronger than before. And once we come out of this, inshallah, we'll be able to have better communities devoid of all the inequalities that were displayed during this process. We pray that Allah subhanahu wa ta'ala allows us to reach the Eid in health and to benefit from these last 10 days. We pray for the safety for all our communities worldwide, to all those who are suffering under different difficult circumstances. اللهم صل على محمد وعلى آل محمد كما صليت على إبراهيم وعلى آل إبراهيم إنك حميد مجيد. وبارك على محمد وعلى آل محمد كما باركت على إبراهيم وعلى آل إبراهيم إنك حميد مجيد. الفاتحة.
Well, thank you, one. Thank you all, and be safe. And from Lancaster Islamic Community Center, we are signing off.